Hello, hi to those who are watching. I am chatting to Dr. Goud today from Laurel Fertility Care, all about stage 3, stage 4 endometriosis, seeking help, testing, diagnosis, treatment options, of course, fertility. Welcome. Hi to those who are joining. Good to see you today.
Hello. Let me get Dr. Goud on here. He should be seeing us in just a moment. How are you?
Very well. I'm looking forward to talking about this today. We're going to be talking about endometriosis stage 3, 4 in particular, and treatment options, correct?
That sounds like a good plan. I'm excited to get into all of that. Maybe you have to send the request. Do you see him there, Dr. Pravingab?
Let me see. Oh, yeah. I think he's got a request to join. Won't let me invite him in. Hang on. Tech. Here we go. Fingers crossed this will work. Hello, for joining. There we go.
How are you doing?
Hello, Dr. Goud. Very
Excellent.
Well. Thanks. How are you? Please, could you introduce yourself to those who are watching and tell us, both of you, tell us more about Laurel Fertility Care, based in San Francisco.
Well, I joined myself Laurel Fertility Care just beginning of last October, and I'm a board certified reproductive endocrine and OBGYN in practice for many years, particularly in the field of fertility for more than 15 to 20 years. I was working in Sacramento for about 10 years, and then I moved in to San Francisco recently. I deal with all sorts of infertility cases, whether we're dealing with assisted reproduction, in vitro fertilization, third-party reproduction, and so on and so forth that we have discussed before. And I'm very happy to be joining the team, and I'm ready for this session with you.
That sounds good. Great. So, shall we start talking about endometriosis, given it is almost the end of March, which marks Endometriosis Awareness Month, but obviously a topic that should be talked about and needs awareness raising all the other months of the year, not just in March. So I guess the first thing is, at Laurel Fertility Care, what are your first steps for testing
just like
endometriosis?
in any other place, we start with the clinical history, examination, and ultrasound. Just to start with, and our focus is mainly on having a very low suspicion on diagnosing conditions, especially such as endometriosis, because it affects almost 1 in 6 of my patients coming for fertility care. So typically we go in the history with symptomology, whether they have any symptoms, particularly those related to pain, but sometimes some other relatively non-specific symptoms, such as gastrointestinal symptoms, which are mistakenly diagnosed sometimes as an IBS, could be constipation, could be bloating, could be pain, and very typical pain is during or after having sex. That's called dyspareunia or painful intercourse. That's a very typical symptom of endometriosis. Also, it should not be forgotten that some women actually may have some mood disorders related to their pain symptoms. So, and then of course the others would have kind of bleeding. So when they come for these bleedings, typically they would go to their own OBGYN physician or provider. But when they come to us, they come as fertility patients, or somebody who's either wanting to have fertility treatment or desire to preserve their fertility in some forms. And in these situations, sometimes we do ultrasound, and in asymptomatic women, we may suddenly notice like an endometriosis lesion in the ovary or a cyst in the ovary that's called the chocolate cyst. We call it the endometrioma. And in case of doubt, again, depending on what the symptoms are and what the patient desires to have in terms of pregnancy, either planning now or in future, we tailor the treatment according to that. For further diagnosis, there are not many blood tests or anything, but in cases of stage 3, stage 4 endometriosis, it may be beneficial sometimes to add more of imaging techniques. And for final diagnosis, one has to resort to the laparoscopy as the definitive method. And the gold standard for the diagnosis of endometriosis is tissue sampling and doing the pathologic diagnosis or histopathologic diagnosis.
And why does it often go undiagnosed
It
for so
goes,
many years?
that's basically because of the relatively vague kind of symptoms and a low level of suspicion. Also that sometimes, the condition has to progress to a certain extent to become symptomatic or, develop into lesions, and that takes certain time. In general, it is known from the literature that about 6.7 to 11 years might pass from the onset of the condition until the definitive diagnosis. But having more awareness, better access to healthcare, and a lower threshold for suspicion in a provider's mind would kind of probably reduce this interval. So I think education and awareness would be something, and I applaud you, I congratulate you on starting this awareness about endometriosis among women.
Definitely needs to be talked about more, doesn't it? And more research needs to be done. Generally, it sounds like with fertility as well. Do you see a lot of patients who have suspected or diagnosed endometriosis who are coming for help with conception at
Yes,
Laurel
as
Fertility
I
Care?
just mentioned earlier, endometriosis is a frequent occurrence among women, almost 10% of women. And then when it comes to fertility, then we have even higher, almost double the percentage in terms of like 1 in 6 or so would be having endometriosis. So when they come for endometriosis, we are aware that endometriosis can not only affect, general cause pain and bleeding and all the other symptoms. It is a major cause for infertility. And why is the infertility? And people have researched and researched over the years, and they found that there is some association between endometriosis not only distorting the anatomy of the uterus and the ovary and the fallopian tubes, affecting the egg pickup, but it can also affect the quality of egg and the ability of the embryo to implant into the uterus. So due to these reasons, we pay particular attention to trying to improve egg quality. And if you are aware, we have done a lot of original research. And in this area, we have found that there is a tremendous increase in the free radicals causing oxidative stress. And maybe there are some modalities trying to reduce that oxidative stress in the environment of the eggs that could improve fertility. So we at Laurel Fertility pay a lot of attention to improving the health of the egg, making an earlier diagnosis, and not to delay treatments in situations where we think that things could get more compounded or complicated. And whenever it comes to definitive treatment, we do have the surgical option as a standby.
Mm-hmm. What can people do to improve their egg health?
So,
as you just mentioned,
there are again, I'm quoting my own study. It was really researched and published in Fertility and Sterility almost 8 or 9 years ago. And what we found there, that even among women with endometriosis, there are some women that are protected against the oxidative stress. And whether this has got to do with inherent factors or whether there, some supplements could help. So we believe that taking certain supplements in form of antioxidants, whether it is vitamin C, vitamin E, maybe there are many other over-the-counter agents such as melatonin, and in general, healthy diet, reduced stress, and all of these things would improve. So we give a lot of importance to these things. And then when it comes to specific treatment related to fertility treatment now or fertility preservation for future fertility, or having, planning the family in the future, we take particular interest in tailoring the treatment to the needs of the patient. And this involves a lot of, interaction to understand the patient's background, ideas, the disease severity, and so on. And finally, we use like a decision tree model to kind of see which way the patient will benefit better.
That's really clear. Thank you for that. If anyone has any questions for Dr. Goud, please do feel free to ask. Also, so we talked about proper testing. What do you do as steps? Tell us a little bit more about a laparoscopy, please.
Before laparoscopy, I did mention that we start off with, like imaging using transvaginal ultrasound. Now, transvaginal ultrasound is really excellent in terms of diagnosing cysts in the ovary, but sometimes we do find very peculiar findings that are characteristics of endometriosis, such as, pockets of fluid in the pelvis, or anatomical proximity of the ovaries to the uterus and in a fixed position. So we can kind of suspect adhesions. But whenever the diagnosis is in doubt and the symptoms are severe, we do resort to laparoscopy. And laparoscopy can be diagnostic or therapeutic. In general, we nowadays don't do laparoscopies just for the diagnosis, but we tend to do the laparoscopy and then we try to treat the lesions. And then when it comes to fertility as a problem, then as I mentioned earlier, we weigh the balance between the risk versus benefit of either option, whether, going towards in vitro fertilization would be better versus going for surgery first and then going for fertility treatment. We make that decision based on an individual situation.
Makes complete sense. And how does age affect endometriosis? Especially,
as you know, the onset of endometriosis in those who are at risk may be happening very early as the age at menarche, but the condition keeps on progressing, and the conditions progress. So typically, the highest incidence that we notice is kind of mid-reproductive age, between 30 and 40 years of age, that we see that the condition is more symptomatic and more diagnosed. However, as the age goes beyond the mid-40s, then depending on the hormone profile, because it is dependent on hormones, when the estrogens in the body starts dropping down, then, there could be some symptom relief. So typically, classically, with menopause, the symptoms of endometriosis are reduced, but may not disappear completely.
Okay. And what about BMI and endometriosis?
Yeah, that's an excellent question. So again, classically by textbook, we always believed over the years that low BMI is higher risk of endometriosis. But interestingly, there have been many studies as well, and I can actually quote you a couple of studies. And what they showed, in fact, is that, one study, for example, from Australia, they saw that even among women with normal BMI, there was endometriosis, but there was a negative correlation. As the BMI went up, the endometriosis incidence went down. However, those women that had endometriosis and had higher BMI actually tended to be more symptomatic. So that was very interesting. And then there was an Asian study actually coming from China or Taiwan. And what they saw is that among Asian women, probably the incidence could be different. And the increased BMI may still have persistent risk of endometriosis. So making the long story short, there is some connection between lower BMI and higher risk. However, newer studies are showing that even with higher BMI, there could be incidence of endometriosis, and putting on weight is not going to help in endometriosis, in short.
Okay, thank you for that. And focusing on stage 3 and 4, as we've been discussing, how severe can it get, and how can it impact
Can you repeat
fertility?
your question again?
For stages 3 and 4 of endometriosis, how severe can it get, and how do you support people with their fertility at these later stages?
Dealing with stage 3 and 4, we are dealing with moderate to severe. Interestingly, those women with endometriomas in the ovary, they are automatically classified there, and those with severe adhesions and deep infiltrating endometriotic lesions get classified as stage 3 and stage 4. In those situations, for example, if you take endometriomas in the ovary, they can have direct impact on the egg quality. They can have, increasing size. The cysts can rupture. They can cause a lot of pain and so on. And when we do in vitro fertilization, we are getting the eggs out of the ovaries. We do get a reduced number of eggs. The ability of the eggs to be mature is also somewhat reduced. And just like I mentioned in our study, we showed that the eggs tend to age faster. So normally there's like a temporal window for optimal fertilization, and that gets affected. So normally, say in about within 6 hours, if the fertilization happens generally, it is likely to result in good outcome. But if the fertilization doesn't happen within 6 hours, these eggs tend to result in abnormal fertilization or abnormal embryo development. In endometriosis, that window could be further shorter. So we try to also minimize the time from the retrieval of eggs to making them fertilized with sperm. And last but not the least, many would be surprised that endometriosis can actually affect the sperm quality. And how is that? That's because the fluids that are secreted and generated, it contain lots of factors, such as the so-called the cytokines and so on. And what they can do is, when the sperm is in the vicinity of the egg, actually these fluids can slow down the sperm. It can make them reduced in ability to enter the egg and cause fertilization. In these situations, actually resorting to ICSI or intracytoplasmic sperm injection could be a good alternative.
Would you suggest that people with endometriosis should have PGTA done with any embryos?
Whether specifically endometriosis affects the chromosomes is not completely proven, but there is telltale evidence that there is some impact. Just if there's going to be impact on egg quality, there's going to be impact on the embryo quality as well. And if there is, this impact on the optimal window for fertilization, then there's more likelihood of generating abnormal embryos. In our own study, we did see a trend of having higher biochemical pregnancies among women that had endometriosis. So extending this whole thing to the PGT platform, we think that PGT would be beneficial for these women. And last but not the least, women who present with endometriosis tend to be a little bit older than those other women who present with polycystic ovaries, or for example.
That makes complete sense. Thank you for elaborating on that. Much appreciated. What are the chances of a healthy pregnancy if you're
diagnosed? And that is an excellent question also. The reason for that is endometriosis, we generally thought just affects, the occurrence of fertility or implantation. But subsequent to that, there is definitely increased incidence of miscarriage, increased incidence of complications of pregnancy, such as preterm birth, premature labor and delivery. And last but not the least, also abnormal placentation, placenta previa. Even women with endometriosis, when they are pregnant, they tend to get higher incidence of unidentified source of bleeding. That's called the idiopathic antepartum hemorrhage, for example. And even after delivery, they tend to have more bleeding. So there are a risk of conditions affecting the baby that are associated with these would be low birth weight, intrauterine growth restriction, and so on and so forth. So and having knowledge about these things, it would be a good idea to plan out a surveillance and close attention to women with endometriosis. They are pregnant, and during pregnancy, they can seek high-risk pregnancy care so that we pick up small little signs that will lead to these conditions, try to prevent them or treat them in time.
Mm-hmm. Great advice. Thank you so much. If anyone has any questions for Dr. Goud or the team at Laurel Fertility Care, please do DM us, DM them for a consult, for a personalized conversation and treatment plan. We have just published an amazing article with the team at Laurel Fertility Care, so thank you, all around endometriosis and diet, nutrition, well-being in sort of stages 1 and 2, and things that you can do to help endometriosis. So please do head to our link in bio to read more and contact their wonderful team. So thank you so much, Dr. Goud. Is there anything else that you think people should be aware of or should be considering or picking up the phone to speak to you about?
I think we spoke over the last 2 or 3 sessions that we had. We've covered pretty much most of endometriosis. Probably we should kind of also consider about a healthy lifestyle, and healthy lifestyle goes a long way in preventing conditions and improving fertility in general. There's some association between citrus fruits and endometriosis. So maybe citrus fruits could have some benefit. And just like that, even the antioxidants, as I mentioned, would have some benefit.
Mm-hmm. Absolutely. Can you give us some examples of some antioxidant
there are,
foods?
among foods stuffs, basically most of the fruits and vegetables would have, and as I mentioned, citrus fruits would have high amount of vitamin C. Generally, vitamin D is more in the dairy and so on. Whereas the blueberries blueberries have vitamin E as well as vitamin C. And then the carrots and so on have a lot of vitamin A. So multivitamins, including vitamin A, D, E, as well as vitamin C, and leafy vegetables will have a lot of folate and folic acid. So all of these are really, really useful for fertility in general.
And what do you think about DHEA?
Now you
for
brought in
egg
a very interesting point. And I don't want to be extending this because it's very important that we understand what DHEA is. Now, DHEA is a very mild hormone that comes from the adrenal gland. And DHEA is interestingly a mildly androgenic hormone. That means it's a little bit of male type hormone. And interestingly, also in the ovaries, there's a role of male type of hormones in increasing the turnover of eggs. So when we are dealing with fertility, we want good egg numbers and good egg quality. So probably DHA could be helpful in some but not all situations. Interestingly, a study that I remember I quote and even discuss with my patients sometimes, they compared DHEA for women, not about endometriosis, but with women with low reserves, and they found they concluded that it doesn't make any difference whether you take DHEA or not. But in the same study, they found that when they looked at the fluid that was around the eggs, and they had higher DHEA content among those women who have made excellent quality embryos. So what does that mean? That just means that their control group had women, that is those women that made their own DHA anyways. So that was a confounding factor there. So there is no doubt that there's some role of DHA, but the problem is how to select that population. Even the blood tests do not help because it's a very local phenomenon in the vicinity of the eggs. So it's okay to take DHA if your doctor is okay with that. The
Does it have any
impact
negative
with
impacts?
DHA being such a weak androgen is extremely small. However, I've had some patients that sometimes, people just keep on taking it for long, long periods of time. And that can cause some oily skin, acne kind of, rashes and so on. So I do talk about those and warn my patients, because we don't want to take something indefinitely. And also the purity of DHEA, and the quality of the product is not so well controlled. So we don't know which DHEA you're taking. And you will see like 5,000 different brands. It's kind of hard to really decide.
Mm-hmm.
You're
Amazing
very
advice.
welcome.
Thank you so much. Anyone who wants to speak with the team at Laurel Fertility Care reaches out and gets in touch with some personalized treatment plan. Thank you to those who are joining today,
Pleasure
and
is
it was
mine
lovely to
as
see you.
well. Thank you. Bye-bye.
Thanks.
Bye.
Bye-bye. Bye, everyone.